Good morning, everyone. Today's Wednesday, October 26, 2022. Thank you for joining us for today's event, Operationalizing Health Equity Practices and Quality Improvement. It's great to be with you all this morning. We welcome everyone who has taken time from your busy schedules to be with us for our third and final session. We have prepared a handout for you of today's presentation, and we've placed a link in the chat. For sound quality, everyone is muted other than the speakers. We do have the ability to unmute lines as needed later in the hour. This session is being recorded and will be available for viewing on iCompass Academy following today's event. We are using our Zoom webinar platform for our virtual sessions. We do encourage you to locate the chat and the Q&A features on your screen. Please use the chat feature to let us know where you're joining us from and to add any comments or discussion. When using the chat, please select all panelists and attendees so everyone can see your message, not just panelists or speakers. If your message is only for the presenters today, go ahead and select all panelists option. The Q&A feature does have a special role. We can use that feature to pose any questions to the presenters. I believe that only the presenters can see your questions that are typed in. We can either field your questions during the live Q&A time, or we can respond to you in writing. Let's go ahead and begin with a message in our chat. Go ahead and select all panelists and attendees from the drop-down menu and let us know where you're joining us from this morning. Go ahead and move the slide. My name is Erin McGuire. I am a Quality Improvement Advisor with the Kansas Healthcare Collaborative. Also joining me today is my colleague, Julia Pyle. She's a Quality Improvement Advisor at KHC as well. Julie and I are pleased to be facilitating today's event. We're also pleased to welcome back Kelly Goodson. Kelly's a thought leader in the areas of health equity and person and patient and family engagement in healthcare quality and safety improvement. Kelly has worked with multiple health systems to improve patient outcomes using the lens of health disparities, identification, and resolution paired with the tenets of quality improvement. She's led a multi-year analysis of hospitals leveraging and deploying PFE in quality and safety improvement that demonstrated a correlation between implementation of PFE and improvements in patient outcomes, specifically lower rates of 30-day readmissions and falls with injury. Kelly co-led national affinity groups for the topics of PFE and health equity for the Centers for Medicare and Medicaid Services and has served on national committees for National Quality Forum and the Institute for Patient and Family-Centered Care. An experienced speaker, she champions the inclusion of patient voices in healthcare improvement efforts and building partnerships with patients, families, and providers to transform healthcare delivery and outcomes. Kelly received her Bachelor's of Science in Business from the University of New Hampshire and her Master's of Science in Integrated Healthcare Management from Western Governors University. She's also a certified patient experience professional. Welcome, Kelly, and thanks for joining us for our third and final session.
Great, thank you, Erin, and welcome everybody. Excited to be here with you today. As Erin said, this is our third and final session as for the topic of health equity. And we're going to start off with just a review of the second program. Hopefully many of you were able to join us, but I will do a quick review here of that program. What we talked about was how, in a perfect world, the different patient populations would have the same outcomes. And in the example that I provided and that you see here, that the different groups of patient populations here all had the same rate, and just think readmission rate in your mind, that everyone had the same rate, even though they make up different proportions of the numerator and denominator, that here everything is all equal. But we know in reality, that's not what happens. When we disaggregate our data, when we take that readmission rate and we disaggregate it by patient populations, we see that patients are experiencing different rates of whatever. This case, let's pretend it's readmissions. And you can see they make up a different percentage of the denominator and the numerator, which means they have a higher share of the burden as well. So not just a higher rate, but a higher share of the burden of the condition, disease, whatever it is that we're tracking. So it's really important to disaggregate data, in healthcare, we've really looked at things at that high aggregate level. But when we disaggregate, we really find where pockets of patients are having different experiences. And I'll give you another example that we used in the last program. Maternal mortality has been in the news a lot, and it's actually been an issue for coming on 40 years now, that maternal mortality rates are not where they should be for the United States. So when you disaggregate the data by state, you can see California actually performs better than the United States average. So that United States aggregate data, when you look at California, they put forth a concerted effort starting in 2008 to reduce maternal mortality, specifically with preeclampsia and hemorrhage. And they looked at clinically evidence-based practices that they could implement that would reduce the incidences of mortality, especially again when it comes to preeclampsia and hemorrhage. But you see, now you could still disaggregate that data even further, and you can see even in California, even though they did this concerted effort, there are still disparities that exist. And this chart is just alarming to see that our Black or African American moms are dying at rates far above everybody else. So this is information that we went over in program 2. We also talked about the HEOA, the Health Equity Organizational Assessment Metrics 4, 5, and 6 that have to do with data stratification, communicating your findings, and trying to resolve any differences that you found. We reviewed some questions that you can ask yourself and strategies and actions that you could consider implementing. And we discussed examples of health systems that have found disparities and have made improvements. Those examples being Rush University Medical Center. If you remember, they put out a health equity report in 2018 that showed all of their disaggregated data and showed where they were doing well and where they had some gaps in their outcomes. We also talked about Novant Health. They won an award back in 2018. It was the inaugural CMS Health Equity Award that they won. And I was really excited to be the one to nominate them for that. They did this fantastic work around disaggregating their pneumonia readmission rates and found that their Black or African American patients had the highest readmission rates for pneumonia. And they used their quality improvement tools, really dug in, found some gaps in their processes, including the discharge follow-up, and closed those gaps. They were able to not only eliminate the disparity, but they reduced readmission rates for all of their patients through that project. We talked about Harborview Medical Center out in Seattle, who disaggregated their colonoscopy screening rates by language and found that their Spanish-speaking and Vietnamese-speaking patients had lower rates of colorectal cancer screenings. And so they implemented a PrEP clinics in those languages led by interpreters so that patients understood better the instructions to prep for their colonoscopy, and those screening rates went way up. So, as we've done on each of these programs, we want to bring up a poll to see what actions did you take from that last webinar we did last month. Did you do the homework? I sent out some homework where you could practice disaggregating your data. Did you take any action around that homework? Did you pilot test the data stratification with one measure? Identify upcoming project where you could stratify data. Were you able to review any existing processes for reporting to senior leadership that you could add disaggregated data to an existing report that you share? Did you review the Rush University Health Equity Report? We talked about the new Joint Commission standards that are coming out in January around health equity. Did you take a look at that information? Let's see, there's a couple others. Recruit a unit that might be willing to engage in this work with you, or nothing yet. A lot of people have competing priorities, or maybe you didn't attend the last session. So I see we're getting some responses in here, and we'll give it another 10 or 15 seconds or so, and then we'll share the results with you. So thank you for participating. Maybe just 10 more seconds, Erin.
Okay, I'll go ahead and end it in 1, 2, 3.
Excellent. So we had a few folks that did the homework and that were able to pilot test data stratification. That's fantastic. We had a few that were able to identify an upcoming project where you can stratify that data. We had a good amount review the new Joint Commission standards. And then we had a lot of people that, have competing priorities, and that's the reality that we're dealing with. And what we're trying to do for you is cut this down and make it simple and give you simple action steps that you can take so that you can embed this in your processes and it doesn't become one more thing. So this is fantastic. Thank you, everybody, for taking the poll. So now we'll get into today's content. So here are our learning objectives for today. We're going to discuss the strategies and actions that you can consider for delivering culturally and linguistically appropriate services to our patients. Describe those organizational structures that support health equity practices, and explain the importance of operationalizing all of these health equity organizational assessment pieces, to really advance your health equity work. So you've heard me say this in previous sessions if you attend, but health equity can become very overwhelming, and what can we really do about it inside the hospital? What is the hospital role? And it really is to build these systems and practices that allow you to identify and address disparities. So again, this is centered around the health equity organizational assessment. This was developed in 2017, 2018 through a grassroots effort as part of this Partnership for Patients Quality Improvement work that's supported by CMS. And what we were really looking to do was just assess a hospital's ability to address health disparities through data collection, data stratification, and those cultural and organizational structures that support this work. So more than 2,000 hospitals have taken the HEOA. And if you remember, there are 7 categories, 7 metrics that we're tracking, and you can see here the standards for each. Today we're on the last metric 7, which is around culture and leadership. So to get right into it, category 7 is again around this culture and leadership. What we're really looking for, the standard we're looking for here, is that the hospital has organizational culture and infrastructure in place to support this delivery of care that is equitable. So we're looking for, the training. Is there training delivered that meets culturally and linguistically appropriate standards? And we're going to talk more about the class standards. That there is a designated individual with leadership and responsibility and accountability for health equity. That the hospital actively involves key stakeholders, including patients and families in the community, in this work. And that the hospital explicitly prioritizes health equity. So for metric 7 to meet this metric at a basic level, what that would mean is that your hospital has a standardized process in place to train the workforce, so the frontline caregivers and even the non-clinical departments deliver this culturally competent and linguistically appropriate services. So questions to ask yourself is, how well do we understand the class standards? And I'm going to go over it a little bit deeper in a second. And how can we leverage these class standards in our processes and practices? And do we train Do we train our staff according to these standards? So the strategies and actions you can take is to review them, and they have implementation checklists and things that are on their site that you're gonna see here in a second, that you can review and use to simply check and see how well you're aligned with the class standards. You can also take this information and share it with the folks that do your training for your staff, and have them look at these checklists and look at these standards and see how well you're aligned with them. And then I wanted to share this really great resource called Ethnomed. It's ethnomed.org. It was developed for clinicians, specifically by clinicians in the greater Seattle area. Actually, Harborview Medical Center and University of Washington are really behind this Ethnomed site, and it's really fantastic. So I wanted to provide that resource for you. So as we think about what is culturally and linguistically appropriate services, it's called CLASS. The CLASS standards were created by the Department of Health and Human Services, Office of Minority Health, back in 2000. And they were updated, they call it enhanced, in 2013. And basically what it is the purpose of it was to provide healthcare professionals with information, education, and resources so that we can deliver care that is responsive to and respectful of the needs, preferences, and values of all of our patient populations. So that is the purpose of the CLASS standards. And they have this really robust website that you can link to here called Think Cultural Health. And there are a ton of resources, tools, guidance out there that you can use. So you don't need to recreate the wheel. You can use the information on this site to see, again, I would encourage you to look and see how well you align with some of these standards. So there actually are 15 standards. The first standard they call the principal standard, which is basically the overarching standard, is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural, health beliefs and practices, preferred languages, health literacy, and other communication needs. So that is the principal standard. And then there are 14 others that are divided into governance, leadership, and workforce, communication and language assistant, and then engagement, continuous improvement, and accountability. So again, would encourage you to take a look at these standards. On the website, they have these checklists. As I said, these are implementation checklists. So they have them under each theme. This one is theme 1. Here's a look at theme 2. But also on the site, they have some testimonials of organizations that are following the CLASS standards and how they implemented and how well it worked for them. So this is the New Mexico Department of Health, for example, but they have other examples out there that you can look at. So I just encourage you to take a look at this site and this information. And I mentioned ethnomed.org. This is really an exciting site. I mean, I geek out about this kind of stuff because this is what I live and breathe, and this is what is my passion. So this site is really a tremendous resource. They have clinical topics, they have cultures, they have information about immigration. You can even contribute to this if you have information that you'd like to give to them that they could consider for their site. So again, this was made for clinicians, by clinicians, and the University of Washington and Harborview Medical Center are they really started this, but I think others are now helping keep this information fresh. So I'd encourage you to check this out. So for metric 7, to meet the intermediate level, so that was basic level that we talked about, was this training to provide culturally and linguistically appropriate services. The intermediate level to meet this metric is having this infrastructure to support this work, which is having a named individual who has leadership responsibility and accountability for health equity. So, this doesn't have to be its own full-time FTE. This, could be a part of somebody's responsibility. What we're really looking for, and questions you can ask yourself is, do we have someone in the organization that's paying attention to this? Do we have someone that is educating themselves on this and that can translate that into the organization to help us with these efforts? Do we have tools, resources that we can use to support this work? And what I've talked a lot about through these sessions is integrating and implementing it within our current processes and structures. This doesn't have to be one more thing. There is going to be an individual or several individuals at your organization that really have a passion for this, that might want to volunteer to lead an equity, diversity, and inclusion committee or a health equity committee. So again, I'm trying not to make this difficult. This shouldn't be something hard, but you do want someone who is really paying attention to this for your organization.
Kelly,
So yes.
we have a question.
Okay.
Who do you most often see that is lead on health equity?
Oh, that's a great question. It really runs the gamut. I mean, I've seen it from, I've seen it run from the quality and safety, areas. I've seen it from nursing. I've seen it from the medical, side, like the CMO, or chief of surgery or chief of the hospitalist. I've seen it from all different sides. So that's why it's like there's really not a one standard. Although I'm gonna contradict myself here in a minute, because I'm gonna tell you something that's popping up on my next slide. But if you're a small organization, it really is who has the passion, who has the most passion for this, and who is well connected throughout the organization that can leverage their social capital to really get this work embedded in processes and practices across the organization. So that's a great question. I'm actually going to hit on a little bit more on that in just a second. So Erin, if I don't, or Julia, if I don't answer the question, then call me out on it again here in a minute. But for strategies and actions, I want you to examine your organizational structures and where you can have this kind of named leader or someone who is passionate about this, and then meet with that person and discuss how you could support that work, whether it's again a volunteer equity, diversity, inclusion committee, or whether you can make it a portion of someone's position. So here's where I'm going to contradict myself. So in larger organizations, there is this shift that I'm seeing of these new positions called Chief Health Equity Officer. So again, these are the larger organizations that can support this work on a higher level. So if you think about equity, diversity, and inclusion, and you think about healthcare, and I think we talked about this in session 1, that healthcare has, the distinction of having the equity, diversity, and inclusion issues that any employer has, right? The employer-employee equity, diversity, and inclusion body of work, if you will. But then we have the distinction of also having the health equity piece when we think about our patient populations, our patient outcomes. So many of the larger organizations are now having a chief diversity and inclusion officer to deal with those employer-employee type issues around equity, diversity, inclusion. And then they're hiring these chief health equity officers to focus on the patient side, the patient outcomes. And some of them they're changing their population health to health equity officer, but really there's even a difference there. The chief health equity officer focuses on inpatient and outpatient health equity. Population health really focuses on the community, the health of the community. So I'm going to stop for a minute, Julia, there and see if that answers the question or if there's additional information I can provide.
Okay, Kelly, I'm not seeing any response. So I think, oh, I have one more question that just come in. Are you seeing hospitals adding DEI into their strategic planning?
Definitely. Yes. Yes, definitely. And again, it shouldn't be one more thing. It should be embedded within your strategic planning. You know, what are the structures you have in place now that supports health equity efforts? What are you missing? Where are the gaps? And those should be included in your strategic plan. Should also be included in your goals. So if your overall goal is for 2023, let's say, is to reduce all-cause harm, right? You can have that disaggregated and you find your most vulnerable patients, your patients with the worst outcomes, and put in a specific goal around that patient population and improving that group. Because if you improve that group, you're going to improve your overall all-cause harm, for example, outcomes. But yes, definitely included in strategic planning. Okay, I'll continue on, but please interrupt if more questions come up. And we'll have, we still have lots to talk about. So for metric 7 is, to be advanced, considered advanced, and you're doing those basic and intermediate things. Plus, you've made the commitment to ensure that your care is equitable, that you've prioritized this, and that you are looking at all of these structures and practices in place to ensure that you are providing this care, and it's evident in your mission, vision, and values. So questions to ask yourself is, have we really made this commitment and put it in writing? Have we really done that? Is health equity specifically noted in your mission, vision, and values? And have you made any pledge to identify and address health disparities? So under the strategies and actions piece, there's this thing called the #123 for equity pledge that you can look at and see if you want to make that pledge. And there are specific steps you'll take after you make that pledge, many of which we've discussed on this series. So it's in alignment with all of the things that I've been talking to you about. So it should not be a stretch for you to be able to make this pledge if you've been following along with this series. And then really look at your mission, vision, and values for those equity components. And I'm going to give you an example here. So here's the 123 for equity pledge. It's actually from AHA's Institute for Diversity and Health Equity. That's where this pledge is housed. That's who kind of owns the pledge. But you'll see, if you go to this website, you'll see the commitment that you'd be making. And there's lots of hospitals across the country that have already made this commitment. So then here, I just wanted to share Rush University, Harborview Medical Center, and Novant's sort of public commitments that they've made to health equity. I'm not going to read them all to you, and they're in your handout, so you have them, but just wanted you to see kind of how they're publicly, committing to this work. And so you can kind of see and look at what your organization has put out, where your mission, vision, and values are, and can you embed health equity within that. So now we're coming to a polling question. So let's think about what actions you can take from what I just reviewed with you. What actions can you take when we're thinking about these structures and practices to support health equity? Can you review the class standards and the implementation checklist? Will you go visit ethnomed.org and kind of see what you see there? Will you be able to examine your organizational structures in place that, all those different things that we've been talking about? Can you meet with your health equity leader and see how you can support their efforts? You can check and see, actually, if you go out to the #123 for equity site that I gave you the link to, there's a map, and you can click on your state and you can look at the hospitals that have made this commitment, because that's, a little leverage you can use. If your hospital's not on that list, but your competitor down the street might be on that list, that's a little bit of leverage to maybe, convince your leaders to make that commitment. And then review your mission, vision, and values for equity, and share this information with others. So there's, multiple choices here that you have. Looks like we're getting some good participation. We'll give you another 15 or so seconds. So maybe, Erin, when we get to 50%-ish.
We're almost there. I'm at 48%.
Just a few more. Few more folks.
Okay, and I'll go ahead and end it in 3, 2, 1.
Wonderful. Okay, so we've got lots of folks that are going to review the class standards and the checklists and visit ethnomag.org. That is fantastic because, just even getting out there and taking a look at these resources and tools is a great step. So I applaud you for that. We've got a lot of people that are going to share this information with others in their organizations, which is great. If this is not totally in your bailiwick and you want to share it with others, that is fantastic as well. And then folks are going to be reviewing their mission, vision, and values for equity, as well as the 1, 2, 3 for equity pledge. So fantastic. So, we're going to hold you to it. Your clinical advisors can kind of, follow up with you and see if you've been able to do that. But we thank you for participating in the poll and thinking about taking those actions. Okay. So again, what can we do about this big issue of health equity? We can build these systems to identify and address disparities. And it really is sort of this team approach. When you think about health equity and what we need to do in order to make any kind of advancement, any kind of improvement, it really has very distinct pieces when I talk about building the system. So we've really been focusing on that orange cog, the inpatient area, because the HEOA is built for hospitals. So it's for you in the inpatient setting to think about all of these different levers that you have, all of these different processes and practices that you're already doing, and how we can add a health equity lens to all that work. There are things that we can do in the outpatient setting that many of them that we've been talking about for the hospital setting can translate easily over to the outpatient setting. So, if you are a health system and you do have some outpatient settings, you can think about some of the work in the outpatient settings that you can do here, namely disaggregating data. Now, it might be different measures that you want to look at in the outpatient world, like hypertension control or diabetes control. Whereas in the inpatient side, you're going to be looking at readmissions, you're going to be looking at CLABSI, you're going to be looking at complication rates, things like that. So the measures might be a little different between inpatient and outpatient, but the steps are the same when we're talking about disaggregating data, pilot testing interventions for those that are having the worst outcomes, right? Really being a data detective, using our quality improvement tools and processes to, again, pilot test interventions to really find out root cause analysis, what is going on for that patient population that's having that worst outcome, where are the gaps for those folks, and then when we shore up those gaps in our processes, it helps all patients. Okay, so very similar inpatient, outpatient setting. We can do these very similar things and work in concert with each other to reduce health disparities. And then there's this big, huge community cog out there. That's more of the population health focus, where we're looking at food insecurity and housing and transportation issues. That's a huge piece of this puzzle. But what people tend to do is they lump this all together in this big nebulous health equity, kind of verbiage, if you will, right? But what we're really talking about is getting all these systems working in concert together to identify what's happening, and what's happening in the community, is very, applicable to what affects outpatient and inpatient care, like transportation. If they can't get to an appointment, then you can't check their A1C levels, and then they might end up in the hospital as a readmission, right? So if you just kind of think about how this all works together, what is your piece of the puzzle that you can do to create this system that identifies and addresses disparities? So here are some of the processes and systems needed to do just that. And you look at, there's a role for administration, there's a role for patient access or registration. The quality team has a role, the frontline teams have a role, and I've identified this and aligned it with the metrics. So when you look at administration and you think about that, that's all about metric 7 that we're talking about today. Do we have the infrastructure that supports training around cultural and linguistic standards? Do we have a named leader? Do we explicitly prioritize health equity in our mission, vision, and values?
Kelly,
Yes, ma'am.
we have a comment as well as a question. So I've been doing my best to de-aggregate data. I've noticed that our race and ethnicity seem to be incorrect. I did some spot checking on patients that I know are multiracial, and they are listed as white or non-Hispanic. These are children of Caucasian moms and African-American dads. To me, this says that we are assuming race and ethnicity, which is absolutely not the right answer. Right. Where can I find the best practices on how to get our staff to be more comfortable with this /screening processes?
Yes, I love that. We talked about that in session 1. So I'm going to encourage you to go back and listen to the recording of session 1. But just to give you a little nugget right now, there's a whole campaign that the Joint Commission, or was it Robert Johnson, supported called We Ask Because We Care. And it really talks about why we collect this data, why it's important in healthcare. And there's a lot of resources out there that talk about the best practices. And again, if you go back and listen to the first session, you'll hear some of those. And I even provide an example with my own family about that. So I would encourage you to listen to that. And there are tons of resources out there that can address just that. But the gold standard to collect race, ethnicity, and language data is what's called patient self-reporting. So we have to ask, we cannot assume, and then that will start to get your data more accurate. So you're leading me right into that next bucket here of patient access. So patient registration has a duty to collect accurate and complete real data. So we need to, as setting the systems in place, we need to regularly train them on how and why we collect the data that way, to help them understand, to help them with how to get the patients to understand why we need this data. And then they can help validate the data. So the best practice is to have 95% of the data collected. And we can also take an extra step and compare that with community data to see if that makes sense. I worked with a hospital one time that pulled their data, and it was like 90% white. And when you look at the community they're in, that's not right. So sometimes you do have to take a step back and really work with our departments within the organization to get them up to best practice so that then we can use more reliable and accurate data. Does that help, Julia? You're on mute, Julia, I think, if you're trying to.
Yes, sorry about that. Yes,
That's
I
okay.
think that answered the question, and there are no other questions right now.
Okay, perfect. So in conjunction with our patient registration area, this is where the quality team can come in and help as well. So, the quality and performance improvement teams are professionals when it comes to making improvements. So they can help validate this data as well, track and validate the data. Sometimes that's a lot to ask for our registration staff. So let's use the strengths of our different departments and have the quality team help track that data. And it can be just, maybe twice a year, you sit down and you look at the data, you kind of track it and you validate where you think there might be issues, where's there missing data, where data might not seem to map correctly either. So in the example that they gave, a white mom with a Black or African American dad, the child should be listed as biracial, but we ask because they might feel because of the way that the child looks that they want to list them as a certain race, and it's up to them. They get to decide, but best practices, you allow for two races to be, two or more races to be selected, and then it's quality's responsibility then to map that correctly to the OMB standards.
Kelly, we do have a comment in the chat. We can only choose one race ethnicity with Cerner. There are times the patient is white and others when they are listed as African American / Indian, etc. Our EHR chooses by alphabet.
Okay. So this is where we got to work with our IT department, our IT systems. And if it comes to that point where you really only can select one, then let's consider some sort of other category or biracial category, because then at least we have more information about the patient. So the goal is to collect the data self-reported, but to also, provide information to us. So if you're just selecting, because of the alphabet, the first thing that they say, and you're not allowing for the additional information to come in, then I would train the staff to select other and maybe make a note if you have freestanding notes, or if you can create a category called biracial or multiracial. That at least gives you more information. Just veer on the side of how can we get more information that's more accurate. And I know sometimes the populations are not high as far as minority populations. So, I think it was session 2 when we talked about data stratification, sometimes you just have to stratify your data by white and non-white. That at least gives you, again, some information that you can go off of. Okay, so I'll keep going, but
Kelly,
these are, yes.
We do have Sean, who has posted AHIP's proposed demographic standards that we released this week to tackle some of the issues. So that is in the chat. Are you familiar with those?
I have not, so I'm excited
Okay.
to see this. We've had a flurry of activity with different national organizations, so I will be curious to look at that. Hopefully they've considered the best practice standards, but what I can do, Julie, is I can look at that and give you sort of my analysis of that. We can send that out to the group after.
Very good.
Okay, awesome.
Thank you.
Thank you. Yeah, there's a lot of work and a lot of action going on with this. So I again, my goal here for you is to break this down into the simplest steps that you can take that will build the systems and the practices that will help you identify and address these disparities. Okay. So let me finish up with quality teams. So the quality team, again, you can help patient registration validate the data and help them track and track and trend the data. Then you can stratify the data and you can identify these disparities, and you can use your projects that you have, your quality improvement, performance improvement projects, to have that equity lens as a piece of it. And then you can communicate the findings as well. You're already reporting a lot of data to a lot of different places and people. So where can you just automatically disaggregate data and share that data with your team members? So those are all squarely around metrics 3, 4, 5, and 6. You see, you have the bulk of the responsibility here. And our frontline teams, we want to include our frontline teams in this. We want to support, we want them to be able to support data collection efforts, especially in the outpatient setting. If they see data missing and their patients are right in front of them, they should be using that self-reporting methodology as well. They can, you frontline teams, if you're starting a project, you can request data from the quality team stratified by different patient demographics. You importantly can attend these trainings and put into practice what you're being taught as far as either unconscious bias or culturally and linguistically appropriate services. So those are HEO metrics 1, 4, 5, and 6. So I've kind of mapped it out here in one way. And another way, here are really the core teams that are involved in this work. So I try to use those same buckets of administration, patient access, quality, and frontline teams. You kind of see the people who really need to be involved in this work. So when we're talking about administration, we're talking about our C-suite leaders and our board. We're talking about a DEI type leader or a health equity type leader, or person responsible, someone that might be passionate, that really wants to take a look at this work. And no step is too small. I think that's one thing I want to say too. No step is too small in this work. If you take a step to do a specific action, that is a great thing to do. Like, don't be hard on yourself. What's that saying? Don't make good enough, be the enemy, or don't let perfection be the enemy of good enough. I don't know, that you can help me out with that saying, but do something is what I'm trying to say. In any step you do is going to step you down that path. So I don't want you to try and take these giant leaps and take on too much, and then everybody gets overwhelmed and nobody wants to do it anymore. Baby steps. So patient access, that's the registration team. The IT team can support the registration staff needs. The quality team, obviously your quality and performance improvement professionals, your data analysts, again, the IT team comes into play there, and then your performance improvement efforts. And then the frontline teams, of course, your medical team, your nursing team, allied health professionals, and even your non-clinical teams really there can support health equity. An example would be, transport. Transport can be trained on culturally and linguistically appropriate services and how to talk to people, how to be respectful, how to, really support people of different backgrounds and whatnot. So,
Kelly,
yes.
we have somebody who knows that saying. It's don't let perfection be the enemy of good.
Thank you. I was close.
Yes.
But that's exactly what I mean. Do not let that perfection and don't let people tell you, well, that's not going to do anything because that's just a little small step. Those small steps build on each other, and next thing you know, you're at that intermediate level of meeting these metrics, or you're at that advanced level of meeting these metrics. Thank you, Julia. So just kind of wrapping up here, and then hopefully we'll have time and have a little more conversation too. But, why do we need to do this? I wanted to kind of end with, why do we need to do this work? We have, changing demographics in this country. So, when you think about it, and this is pretty well known, that we're going to become a majority minority nation, I think is how they say it. But we're growing. We're growing as a nation. We're becoming more diverse. And again, with session 1, I talked about my own family. I have a biracial family. And so we did this practice with my husband around guessing his race and ethnicity, because it's hard for people to guess, what his background is. And then when you look at our children, they all look very different. You know, you might never think that my oldest son there in the foreground, you know, you would never imagine that his father looked like what my husband does. And, you know, when I walk around with my middle child and my daughter, you know, a lot of people, you know, don't think of them as biracial. They think of them as white, honestly, which then they have nice tans is the comment I get a lot. So we are becoming a very you know, multicultural, biracial, multiracial nation. And we talked about the human costs of quality in on our maternal and infant mortality, which is just striking. And it's just so sad because we know, you know, we can fix this and we just haven't yet. And it's just, you know, it really, we have to address this. And a lot of what it comes down to is, you know, teaching our clinicians to listen to women, even if it's their first pregnancy, they don't feel like something's right. We need to listen to that. We need to understand that every woman feels pain in the same way. We need to understand, you know, that there, you know, we just need to trust our patients and our moms that if they say something's not right, then something's not right, and we need to investigate that.
Kelly, we have a comment in chat.
Okay.
You bring up a real point, which is that I wonder if the public can even answer the race and ethnicity questions about themselves. This adds a barrier to collecting the data accurately.
Well, it shouldn't, honestly, if we're asking in the right way. And I'll use again my husband, for example. So my husband actually was adopted by a Black family. His birth mother was white, birth father was Black. They were teenagers, but he's adopted by a Black family. So if you asked him growing up all his life, he would say he's Black. You know, now that he's older and we're married and we've got biracial children, you know, he actually will say, you know, a few times now, I won't say it's a majority, that he is biracial. So people know who they are, but it might change over time. So as part of the best practice that I talk about is verifying that information every year, or, you know, whenever you can, is verifying that information, because sometimes people, you know, make changes, but they know who they are. And we just have to help them understand why we're collecting it and giving them as many options as we can to, you know, let us know, you know, racially and ethnically how they identify.
Kelly, Deborah has shared a great paraphrase to the quote we gave earlier, and that is, don't let good be the enemy of better.
There you go. See? Fantastic. I've got people thinking this is wonderful.
Yes.
This is wonderful. I just have a couple more slides here. I've got, you know, there's a huge economic cost around disparities, that if we can eliminate disparities, we can, you know, improve by $135 billion per year, you know, savings of costs of $135 billion per year. We of course have this Joint Commission standards that are coming into effect January 1st, that they want to see that your organization is identifying and addressing potential disparities. This is CMS's equity framework that they just put out for 2022 and 2023. And I want you to pay attention to priority 1 and priority 3. So priority 1 is the collection and reporting and analysis of standardized data, and that they're talking about patient demographic data there. They're talking about all data, including patient demographic data. And then priority 3, they're talking about building capacity of healthcare organizations to reduce health and healthcare disparities. And finally, my last slide, you know, I want to leave you with this quote, and I want us to consider, you know, being part of the change. So this is a famous Martin Luther King Jr. quote: "Of all the forms of inequity, injustice in healthcare is the most shocking and inhumane." And that to me hits to the heart of the maternal mortality issues that we have. And then I really like this quote from Dr. Satcher, who is the director at the new Morehouse School of Medicine. To eliminate disparities, we must know enough, do the research, disaggregate the data, understand what's happening within our own organization. We must do enough, deliver on those outcomes, pilot test those interventions, spread what works. We must care enough, make the commitment, make that public commitment that we are going to work to identify and address disparities, and then persevere enough. Don't get discouraged. All the quotes that we've been talking about go to that piece. This is tough work, and a lot of people will shake their kind of head at it, shake their nose at it, say, we don't need to work on that here. That's not a problem that we have here. And that's why we really have to take a look at how we're collecting data and how we're analyzing data, because from the national data, that's not true. It's everyone says that might be happening somewhere else. It's not happening here. Well, let's prove it then. Prove it that if it's not happening here, or you just might find some disparities that you can actually do something about. So I will stop for a minute, Julia, and see if there's other questions, other comments that you might want to raise up.
I'm getting a lot of responses in chat, just commenting what a great presentation this has been, as well as a great series. I don't see any other questions. Does anybody have any other questions? The slides are available on our website, as well as there is a link in the chat that you can cut and paste, as well as iCompass Academy will have these slides on their. Okay, Kelly, I'm not seeing any other questions.
Well, while folks are still thinking and welcome comments and questions in the chat, this is the last of our series, but I hope this is not the last of the action that you're going to be taking in this space. So please use the questions and strategies and actions to think about and guide your next steps. Use all the tools and resources provided in this series to continue this work, and really partner with your clinical advisor. And they can keep you on track and hold you accountable for doing this kind of work. And I really want you to track your progress, because as I said, at times this can be very difficult and those baby steps don't feel like you're doing much, but please trust me that they are. And you have to build those baby steps and before you can become more intermediate or advanced. And just speaking of tracking progress, I think you all may know that the Compass HQuick does track the HEOA assessment results. So this was data from September 2020 to June 2022, so just June, a few months ago. So they track these 7 HEOA metrics and where folks are at, and then they practice what they preach, and they disaggregate the data by state. So we know by state where our healthcare organizations are within each state. So that's something we're hoping that we see through this series, that these metrics do improve as part of this. So that's a way that we're tracking at the Compass level. When I say we're tracking at the Compass level, how we're helping you all take those baby steps and put into action some of these systems and processes that can identify and address disparities. So with that, Erin, I'll turn it back over to you.
Thanks, Kelly. We appreciate it. I've enjoyed these 3 sessions, and you just said something that really resonated with me. You said, let's prove it. I know sometimes when we're thinking about answering this health equity organizational assessment, doing the work in our hospitals, in our community, sometimes it feels like, we just don't have the minority. But you know what? Let's prove it. Let's get this work underway. Let's really dig into the HEOA surveys, and let's prove that we don't have a big gap as what others think we may. So that resonated, just that little line there.
Okay.
Just a few messages before you guys leave us for the day. As you do leave, an excellent call to action is to use the strategies and actions that we've learned throughout this series to guide you on reviewing and updating your next HEOA assessment for your facility. Our next reporting period for the health equity organizational assessment is due with your December data. So the data portal will open the first of the year, 2023, and then your data, including that HEOA, is due no later February 15th, 2023. For our Kansas hospitals, your QIA will be sending out your HEOA survey early December via email.
Kelly, sorry to interrupt. We have one late question here that I wanted to pose to you.
Okay.
Just a comment. I don't see that Kansas has any hospital on the 1, 2, 3 for equity. Can you speak to that?
Oh gosh, that surprises me because
Well, actually, well, hang on. There is another comment that there are 16 hospitals.
Okay.
So scroll down on
yes,
that
sometimes
list.
you do have
Yep.
it's a little wonky. You click the map and then the list comes up, but sometimes you do have to scroll down.
Okay. All right. Okay, sorry, and thank you for answering that last question.
We've posted on the screen here and in your handouts contact information for our Compass H-Quick leadership. I always do encourage you to reach out to your quality improvement advisor or your CIC for your state, but there's also leadership contact available. You want to be sure to visit iCompass Academy to participate in our recorded and on-demand educational events. Previous webinars, including this series, will be posted here. Next slide. We encourage you to join us on our communication platform, iCompass. iCompass is filled with great resources and information to drive sustainable healthcare transformation. And then feel free to follow us on social media. All of our handles are posted here. And then finally, as you leave today's session, you'll be directed to a brief survey. We invite you to let us know what a key takeaway was from you from today's event. And on behalf of the entire Compass H-Quick team, we thank you for joining us. Have a great afternoon, and we will see you soon.